Thanks, Chairman. I think Vijay has sold the procedure to the select young active group quite convincing. My sort of brief here is to discuss some issues. The traditional teaching and wisdom, we all know about the position of the cup inclination, the anteversion. But all this in the earlier studies, where Leoninek was aimed at minimizing the dislocation. The whole focus was how do we minimize or avoid dislocation. But is it the final word in the change scenario or the circumstances today? I think it's a no. We need to discuss this. Like he mentioned, the large heads have come into play. Our head size is progressively increasing. The bearings are getting harder in a select subgroup. They increase the range. They increase the impingement-free movement and the stability. But of course, hard bearings supports intense activities, but some malposition can get accommodated was the misconception that if you put these cups slightly malaligned, still it will sort of not fail. But the fact to sort of remember is the error margin shrinks the larger the head and the harder the bearing. Basically because you sort of malposition anyway, we have the concerns of edge loading, impingement, and the stripe wear, and we all know about the catastrophic consequences of even product withdrawals. So when you talk of optimizing the cup position in the primary, I think 5 points I thought probably needs mention. Is it that the same standard yardsticks are applicable across all pathologies? How do we factor the morphologic changes you may see in certain indications? What's the impact of the lumbar spine and the sagittal changes which is being increasingly discussed? Techniques to fine-tune, and how do we assess and evaluate radiologically? Because all this will have some influence on the wear rates of these. I think Biverland's paper about the use of TAL has been something which is standardized, which is used by most surgeons. Yes, this is a good process and a procedure which is probably applicable in most of the standard pathologies, but there are certain situations where probably one has to look at it with suspect and probably may use to use additional steps. For example, dysplasias, probably not so reliable. Old trauma, questionable. And if you have a crossover sign or retroversion, probably you can't depend purely on the TAL to get the fine position. So in these situations, you need to probably address and look in, think about how we are going to factor the change morphology and how you adjust your socket position. Dialing version and inclination as a per-operative guide, normally, if you use the TAL, you could use the outer margin or the inner margin of the TAL. And usually, as a mathematical guide, a millimeter of uncovered anterior margin of the acetabulum or the uncovered segment of the TAL would be a good guide. And it sort of equals 3 degrees, both in anteversion and inclination. But this is rather arbitrary. I just tell you to what we use, which I saw in our unit, we created what is called the TAL index. That is amount of uncovered transverse acetabular ligament from the inner margin gives us a good guide. You sort of quantify this and you are able to accurately predict how much is going to be a cup inclination. So I think this is a good way and this is a practice we use at our center. TAL is good in inclination, but in version probably sometimes it may be difficult to assess and probably may not be accurate for 2 reasons. One is reliability, and second, how well are you able to quantify and numerically quantify during our analysis post-operative. For example, if you look at these X-rays, sometimes you get a beautiful end-on X-ray, but are we right? The question here is, if you look at the X-ray at the top, it may just be that this is neutral or slightly retroverted. So how do we calculate this? You want something which is appropriately anteverted, and this can be sort of calculated post-operatively. Various radiological techniques have been discussed and defined to you assess the anteversion. The one which probably has the best sort of outcomes or which is most reliable, comparable with the CT data, is the Wiedemar's technique as described in these techniques. So I think anteversion is still probably something which is difficult to assess and quantify appropriately. In complex situations where TAL is not reliable, use multiple options. One, spatial orientation jigs. Second, assess the desirable position. Probably like you saw in the videos, do the femoral trial, do the acetabular trial, assess your combined anteversion, and then so that you can factor and fine-tune and adjust on the femoral side as required. Your aim one should be to get desired anteversion of approximately 30 degrees. So how do we factor the pathologies? This is something we very commonly see in this part of the world: pelvic obliquity, fused spines, or sometimes a long spinal fixation device. The concern here is, if you use the standard landmarks, there could be impingement and dislocation. One simple sort of understanding is, when the lumbar spine is kyphotic and it is fixed, I think you find that the whole acetabulum rotates. This is just simplifying the understanding here. So the tal from inferior goes to the anterior side. So this totally throws everything out of gear, and this has to be factored. The same thing in the AP. So when you have a fused kyphotic lumbosacral junction, decrease the anteversion, and have probably slightly more abduction. One X-ray here. On the left side, it was malpositioned, but once you understood this and recorrected on the other side, you are able to fine-tune the position. So I think keep that in mind. There are more and more publications coming on this subject, and it clearly shows there is a significant influence of the lumbar spine position on the final outcome, and we need to factor this. The standard positions may not be totally accurate. And there have been certain mathematical formulae which has also been defined, which could be useful in that we can do the anterior pelvic plane assessment preoperatively and use this as a mark to finally calculate and align our sockets. This is another one, the same paper on the same subject, which helps you to assess. In technically fine-tuning, if you're a lateral position yourself, make sure the fixed landmarks and make sure the patient is stable. It's very, very important and best done by the surgeon himself. Mechanical jigs have a flaw in a sense, whether you use the imageless guide or the thing that the socket is a mobile target, the positional change can influence significantly the pelvic tilt. It does not factor the sagittal orientation and assessment, and there could be some perception error. We should be careful about this. More reliable and reproducible combination of the jigs, patient position, and in case of a significant osteoarthritic situations, make sure you're able to position the tal by removing the inferior osteophytes. And this could be some sort of a small point we should be careful about. Imageless navigation is seen to have the same flaws, so be careful about this. But image-guided seems to be the way to go. This is the reports from Sugan and co-workers. At 10 years, you find dislocation rate much less, impingement much less, and they have published that the error margin is minimized considerably. So probably image-based navigation may be the way to go in the future, because you can better plan, reproduce consistently, and factor the issues that influence the outcome. So ultimately, what is ideal? A good combination of anteversion, impingement-free range, and eccentric loading. And Vijay in his publication also alluded to the fact parallelism of the implants is one that can ensure sort of a neutral loading. And if you have this, I think this is intuitively more attractive, that can minimize the wear and minimize the edge loading. So in conclusion, ideal positioning still debated. Mechanical jigs at best as an aid. Reliability is questionable. TAL is reliable in most situations. Use the TAL index in consistently helping you to position the implant. Ideal to have a load axis central to the construct. Aim for combined anteversion around 30 degrees, and it's the best bet to avoid edge loading. Image-based navigation may be the future direction. Thank you.